Okay, so we were just introducing ourselves. So my name's Liz Molloy. I work here in the Department of Medical Education, and I have, I suppose, a couple of roles. One is Director of Work Integrated Learning. So I'm particularly interested in how we design clinical supervision in the workplace for our students, and also researching the effectiveness of that. And the other role I have is faculty-wide, is looking at interprofessional education and practice. So I'm very interested in collaborative practice and how do we socialise our students into getting better at making referrals and also working as part of healthcare teams. And here's Brett.
Thanks, Liz. So my name's Brett Vaughan. I'm a colleague with Liz in the Department of Medical Education. And my predominant role is with the Master of Clinical Education and working with people like Anne over the development of their project in that Master of Clinical Education year. But I also do some teaching into the Excite program through both the graduate certificate and the graduate diploma. My interest and PhD is in clinical education, and particularly evaluation of clinical educators is my PhD topic, but more broadly interested in assessment and evaluation across clinical education.
Thank you. So I think it was really interesting when this collaboration came out around how do we bolster supervisory capacity in rural health. One thing we talked about is the problem with having short courses is we drop them in and then we expect people to take up the principles and then directly translate it into practice. And I think we've got a fair bit of research published around the world that shows that once-off education interventions aren't particularly effective when it comes to sustaining behaviour change. So in terms of this design of this CPD, we thought, yes, we can run some one-day workshops. We can also have some follow-up webinars on particular topics. So we did roll out working with the poorly performing learner. We talked about advanced feedback, and also Charlotte Denniston gave a session around teaching on the run. So really about how do we facilitate learning in compressed, busy environments. Yep. So we've run that across the last 3 months. And we thought maybe the third component that's lacking at the moment, lacking in terms of offerings, is this sort of model of community of practice, or what Deb Butler from Canada is calling collaborative inquiry. And that is really hearing from you guys about, based on the education you've had so far, what's been your goal in terms of changing your own supervisory practice, and to what extent have you been able to enact that or not enact that, and sort of, if not, why not? So we were really keen, I suppose, to hear from you about what you've been working on and what you think you might need further in order to refine your practice. Fantastic strategy, and I think particularly acknowledging our tendency to have blind spots. So we can know what our goal in practice is, but we're not always good at picking up the degree to which we can translate those things. So I think the use of peer feedback is a really good strategy. The reciprocal nature of something like feedback, or even broadly clinical supervision. And I do suspect that there's something about putting people in a different role that makes them see the process differently. So I imagine by them having to give feedback, that when it comes to them receiving feedback, they may be more open to the fact that, you know, it can be an emotional process, or, you know, it's quite hard for the supervisor to pick out the big nuggets of gold when there are so many things perhaps to work on. I mean, yeah.
I was going to say, I think it's absolutely a challenge across a lot of health profession education programs, because we want to find out a lot about what we're doing, how we're doing it, how well it's going, or what could be changed. And I think it's probably a really big opportunity that's being missed as a professional development opportunity for us. And so maybe that's something that we need to think about from our end, about how we can put forward evaluation of clinical educators as being a key thing that the students need to be, or we really want them to be involved with. And I think a really good way of doing that is to show that we actually take that feedback on board, talk to them about what the collective feedback is and what's going to happen from that feedback. So they know that it's not just a survey for a survey's sake. It's more that they have an opportunity to put in or see this process being enacted. Definitely.
Yeah. And I think we talk within the one-day clinical supervision workshop, we talk about evaluation of clinical teachers and the fact that students are strategic, and sometimes they would be well served to say, this has been the best placement I've ever had and you are very informative and thank you for your teaching. Yeah. So, I mean, for them, they're learning a skill that probably they need throughout their career about what information do you give at what point in time and to what effect. And I think it would be great if we had a culture of safety and they felt that they could be frank. But you know, sometimes I think we need to have that trust established, and maybe different types of information at different points in their placement we need to collect to make sure we're getting a fairly accurate picture of their experience from their perspective.
That's right.
I mean, it reminds me of what Brett was just saying, is that I think if students see that their feedback has an impact, so, you know, if you say, I've responded to your feedback and in fact these sessions are now 20 minutes and not 45, it starts to boost the currency of their own feedback and they're more likely then to be candid. Yeah,
absolutely. And they're also more likely to trust the process as well. And that's a big thing I think we talk about quite a bit through all of our courses, is this development of trust both ways between educator and the student. And so being able to see that feedback from the student being enacted helps to develop that, because they can go, well, I know I'm having an impact here on my learning, but also the learning for subsequent students.
Yeah. And it makes sense. Yeah, I think if you're going to put some information out there that you think might actually threaten the relationship or threaten your chance to get a job back in your particular clinic, then at least you want to know that in fact it's going to be picked up and used. I agree. And I think in a funny way, that's why I don't mind some sort of structured instrument to collect this data, because I think, you know, when you are a novice and someone says, what's the quality of your clinical teacher? The one thing, I mean, I think clinical teachers, also we all fall into this trap as well, as thinking that clinical supervision means a certain thing. And there's something about, for me, something about the MCTQ is that breaking down or itemising what constitutes clinical teaching that may give us quite different data to saying what was the best thing about this session or what could be improved.
I think it's nearly a slight separation between the development of the teaching session versus the actual delivery of it, and what you're doing as, I suppose the idea of being a clinical educator is really around the development of these interpersonal skills and behaviours that work with the learner. And then there's the next part, which is actually the clinical teaching. So what is it that you're actually physically working with the learner on? And they're very much interlinked, but the students are generally quite good, particularly later on, at commenting on that teaching side, because they know what's happened, what changes or what could work for their own learning. But even early on is they can actually comment on those interpersonal behaviours. Are you sort of building up their confidence, developing that trust?
Yeah, do they feel welcomed into the department?
And things respect. They've got the ability to communicate with other health professionals, yourself, those sort of things that do come through in those more structured questionnaires.
So what would you say, so in terms of your current roles as clinical supervisors, what do you think is the most difficult? What aspects of clinical supervision practice are the most sticky and tricky?
A real positive for that strategy as well is that it demonstrates your genuine interest in them as a learner. Rather than us just providing feedback because we feel that's our role as a teacher, there's actually that reciprocity that comes with, yes, they're having to direct their own learning, but you're there to help facilitate that learning and really encourage them along by doing that process.
Indeed. And yeah, as you said, you're exercising, you're using your two ears because you're asking for input rather than you providing a direct input.
Exactly.
Yeah. I mean, the other thing that springs to my mind when you talk about when you try a new strategy and then you get the blank looks from the students, it really makes me think about this concept of holding your nerve. Because I think so often when we try, and we do it in the classroom as well, so we might be used to delivering a lecture from an expert, getting really good student feedback because it's didactic and people get a whole load of information by a perceived credible expert. And if we mix that up and get the students to do work in that session, they may tell us that that wasn't nearly as good as last year. And that is an example where I think we have to hold our nerve and think, well, what are the educational principles underpinning this? And why do we want students to work in this session? Because we think they're going to take ownership and they're more likely to retain the knowledge. And I think exactly right when you said that you want the learners to have some sort of input into these performance conversations. They will look at you blankly because they're not used to doing things in this way. So I think it's a really important comment, and maybe this is something that we need to build into our Excite programs and into our short courses, is this idea of don't expect the students are going to jump and thank you or actually have the language to be able to participate in these dialogues, and that you need to sort of scaffold these self-evaluative behaviours. Worried that I'm missing out on these big, sexy cases that are happening at Alfred ICU. Yeah, that part of your rationale for what you think they're learning in this particular region and through this placement, and hoping that over time they start to sort of migrate to your rationale as well. Yeah. And I think likewise, going back to that point when you ask someone, you know, what do you want feedback on, and they look at you blankly, maybe we have to be more articulate about, well, the reason I'm asking you this, Brett, is that if I attend to what you're worried about, you're much more likely to hold on to the resultant messages than if I just bark at you. And perhaps we, as educators, perhaps we're not being explicit enough about the underlying rationales. Yeah. So, so that, going back to what you're finding tricky, we had the defensive student in terms of receiving feedback. Are there any other sort of struggles that are popping up?
Yeah, absolutely cultural, I think, does play a part, where we're not particularly good at identifying nor verbalising what we're actually good at. We don't often feel as though we can or we should. But again, it's developing that relationship with the learner and that trust that you want them to express what they're doing well, and there's a reason why it's going well. And hopefully to try and get them into that frame of mind that you're someone they can actually say, look, I am doing this really well, or I think I'm doing this well. And maybe the initial stage in is actually something, might even be something quite straightforward as far as that Pendleton model, where actually the first thing I'd like you to do is to tell me what you think you did well. And just use a really basic, simple strategy asking that question. Or if they're really even struggling with that, is to highlight, actually, these are the things that I observed that you did really well. And just start to build that trust and that confidence that they can articulate what they do well. Because that'll help them with their own reflection anyway, further down the track, I think.
Yeah. It's very tricky, isn't it? Because we're using a scoring system, and we're sort of, no wonder they're orientated to numbers, because we're using numbers. And I think more and more the assessment research, particularly workplace assessment research, is showing us how powerful qualitative comments are rather than the scale. So I think for every item when you're scoring out of 5, I think it's really important that you justify, why the score was this way, and really orientating the learner to what the standard of performance is. So I think the storytelling around why you're making the judgments you are is the most important part of engaging in a mini CEX. Yeah, because if you just go down and say that's a 4 and that's a 5 and that's a 3 and that's a 2, then they're going to start to think that way.
Yeah, agree. And it's probably even highlighting or getting the student to, or students, so not only the student that you've talked about, Javier, but probably more broadly, is our students developing this understanding of what the assessment is about, what it's being utilised for. Then that will help them in part to orientate towards the standards that are expected or the standards that are being assessed. And that will help develop their understanding as well of what that 3 actually means. Because if we don't, as Liz said, if we don't have that connect between what the 3 means and some sort of qualitative commentary around it, whether that be from a rubric or the comments that we provide, the student just sees, actually, I'm middle of the road.
Yeah.
But they don't know what middle of the road is. And that's where they start to get a bit anxious or angry or disappointed because they're not sure where the next step to improve is and how to go about it. And I think that's where the value of the mini CEX is really in those comments about what's happening next. What are we going to do to help you improve the score, to change the comments here, to move up the scale and go, actually, your performance is improving.
Yeah. I think it's such a great point that Brett makes, that if your comments are forwardly orientated, so if it's all about what that person needs to do in concrete terms to migrate towards the right of the scale, then people are automatically less emotional about it because you're talking about what they need to do, not something that's firmly rooted in the past and they can't, you can't change the way you've just performed, but you can change what you're going to do differently next time. So we find that if you're using language around what to do next and when they're next going to have an opportunity to perform a similar task, then they tend to be much less emotive about the feedback you're giving.
Thank you.
The other strategy that I think is used quite a bit is that what we call that normalising language, where people say, you've got a 3 out of 5 for these reasons, and this is what a 5 would look like. And then they use things like, this is really common for this point of being midway through second year. Or we find that first year registrars really find this challenging at this point. It's really natural, and you'll find with more exposure and more practice that you'll start to be looking more in this way.
I think to follow that too is there's a really great opportunity as a clinical educator to be involved in that process and to sort of, I suppose, get some buy-in from the learner to go, look, I'm actually going to help you along that journey. So it's not just the feedback that we're talking about at this point. I'm actually going to be involved in helping you in your journey to be a health professional.
Yeah. Yeah, so like a really good example of that, what Brett's mentioning here is when people use even the inclusive we. So the pronoun use of, I think, what you need to work towards is this. And what we can do is next week we can set up the patient in this way. And there's something about that inclusive we where the learner feels like, yes, Brett is invested in my performance and is invested in helping me improve. It's not rocket science, is it? It's such a simple component, but if people feel like you've got their best interests at heart, they will jump a whole lot of hurdles and they will really invest in the work.
Exactly. Yeah. The strategies there is even encouraging them to bring the previous feedback that they've got on their mini CX to you to help then formulate or help the learner formulate some learning goals for when you're working with them. So you can go, well, okay, previously this is the feedback that you received. I think we've got an opportunity to work on these things over this part of the placement. These are the things that I'd like to really help you with, potentially by doing or this strategy, or we've actually got these patients coming up. I think this will be a really valuable opportunity to work on some of those points from your previous feedback. And again, I don't think it's something that even system-wise that we're structured well enough to really capture that. And so encouraging the students to bring that feedback, I think one, gives them some ownership over their own feedback, but two, it helps you understand where they're at, what you can potentially help them work on, and that builds a whole lot of confidence in their placement as well. Yeah, that's exactly it. And really the design of the Mini CEX, when it was originally developed, that's what it was for. It was actually about ongoing feedback to help improve performance. It's just, unfortunately, it sort of morphed into something that it probably was never designed to do.
We need to look at what's happening in terms of postgraduate medical education, and also even sort of CPD revalidation sort of work. And we are moving to a portfolio type design where students are the owners of that information, and and most of this data will be available on a dashboard. And they will sit down with different supervisors and say, here's my feedback to date, and this is going to guide my goals for this particular day, or my goals for a particular placement. But it is interesting, because I think back in the day when I went through clinical placements, I think there was a degree of this sort of longitudinal assessment. And funny enough, I think it's been around the movement around cognitive bias and assessment bias and protecting the well-being of the student, where we've treated placements as these discrete learning episodes. And I think it's a real shame that incoming supervisors don't get the data from previous placements or episodes.
And really the analogy for me is a patient handover in clinic. We do a patient handover obviously for safety reasons, but ongoing care. But we don't do the same with our learners.
Yeah.
And so there's something there, I think, that we can really use that idea of that handover as a way of helping the student in their journey, particularly where we only have the learner for a small period of time. In some cases, a bit more, a bit longer in a rural setting, thankfully.
Yeah.
But certainly in shorter placements, it's something that we don't really utilise a lot.
Yeah.
And our systems aren't designed for it.
Yeah, I agree. Well, thank you all. And obviously from a quality improvement point of view, what comes up as well, we think about how does that align to the objectives of the courses, and if we feel like people are struggling with certain concepts, then we can go back and refine those particular elements of the baseline courses. So we'll be doing stuff, I suppose, with this information.